by my friend Sandeep and his team that we have started this ERCP series. So our main purpose was to educate and try to help the fellows who have started under ERCP, especially newly. And in this series, I'll be presenting the challenging task, and as Dr. Lamba told, that it's difficult for everybody. So, definition of altered anatomy is a stomach. Either there's a stomach surgery which is partial or complete removal of stomach, or there is no removal. Then there is a duodenal bypass. Either there is creation of a gastric access loop, or there is a percutaneous access loop, or patient has a altered the CBD, that is hepaticojejunostomy. So the anatomy will be like patient presents with the altered anatomy with either intact papilla or patient has no papilla. So patients who have an intact papilla, their anatomy is like they have either a roth 1, roth 2. They have undergone a subtotal gastrectomy, or they have undergone a roux gastric bypass, or they have side-to-side gastrojejunostomy. And patients who present to us with altered anatomy and no papilla, these are patients who have Whipple surgery, patients who have roux gastric bypass with a hepaticojejunostomy, patients who have undergone a choledochojejunostomy, or patients who have undergone a choledochoduodenostomy. So these are the situations which when a patient comes to us with the altered anatomy, these things should be kept in mind, and we should see whether patient has papilla or no papilla. So I'll tell in future slide why does it matter. So before we start attempting ERCP in such patients, there had to be some checklist. So the checklist is we should review the operative reports, understand the post-operative anatomy and lengths of reconstructed limbs, clarify whether a biliopancreatic anastomosis was created, and it's better to discuss with a colleague who has done the surgery, or with your surgical colleague to understand what could have been done in the surgery. And there should be a review of all radiological, that means not on the current but old reports at the time of surgery if available, because the indications will, if we know the indication, then the type, then we are pretty clear, and things should be clear on that matter. And we should be selecting anesthesia depending upon whether patient should require a non-general anesthesia, or patient should require general anesthesia, and the position of the patient, whether patient ERCP can be done in supine position, prone position, or in the lateral position. So patients who some patients, like patients who have undergone a percutaneous access loop, the ERCP can be done in supine position. And the point I want to focus is endoscopes and accessories, which I'll be discussing in detail. So patients who have so whether it requires a forward wing endoscope versus side wing endoscope, the standard length versus long endoscope is required, a single versus double balloon is required, other accessories which are required, a therapeutic versus a standard accessory, and like this, and the consent, because the goal, risk, and benefits of procedure should be explained in detail before we attempt such procedures. So the key point which we should be focusing is, one is what is the length of the bowel which we are going to attempt, status of the patient at the time, whether it's in cholangitis, or patient is sick, or patient is stable and undergoes the procedure. There should always be a backup strategy in the mind, and there should be always another strategy, like a radiologist should be involved, or a surgeon should be ready if we fail with the procedure, or we develop or there's a complication. So these are the scopes and accessories. You can see that the therapeutic duodenoscope which we use for ERCP has a working length of 124 centimeters. So you should understand that the most of the accessories for ERCP are less than 150 or 250 centimeter. So if we are planning to attempt an endoscopy, ERCP via a small bowel or a colonoscope, then the length of accessory should be long. And the biopsy the channel caliber channel is 4.2 millimeters. So that gives us access or leverage that all stents, including largest stent, that is 12 French stent, can be deployed by using the standard duodenoscope, and all ERCP accessories can be used. In excess, the elevator is present in a ERCP scope, which is not present in the other scopes. And when you see adult colonoscope, the length is around 168 centimeter. The diameter is the therapeutic diameter is 3.7 millimeter, and up to 10 French plastic stent can be deployed. But beyond that, the stent may not pass. The shortcomings are that there's a lack of elevator, And I'll show you later on that it is best used for patients who have biliary 2 or post-vipal anatomy. It's not good for patients who have very long limb. And other is a single balloon versus a double balloon endoscope. The length is 200 centimeter, and the working channel is 2.8 millimeter only. So only a 7 French stent can pass through these scopes. A bigger stent, double wire is sometimes difficult. So we should only pass one by one stent, and there is no elevator in the stop wire. These are best suited for a Roux-en-Y hepatogenostomy or Roux-en-Y anatomy, which have a long afferent limb. And it always requires overtube, which is normally not present in other scopes. So these are the standard single balloon endoscope. You can see the endoscope and the presence of. So I usually use a APC, the old APC probe, which has a forward viewing or the forward facing opening, not a lateral facing. And this I use because the length is more than 300 centimeters. So I use usually this or a bile cannula. And this is a the S-shaped cannula or a typical biliary 2 cannula. So basically, I will show in the future slides that how does sphincterotomy and cutting is done. So it's always done in the inferior, that is a 6 o'clock position. So that's why the cannula is oriented like that. It will cut downwards, not like upwards, but normally what we do in a normal routine ERCP. So what are the options if patient who has a altered anatomy? So if there are three major anatomies which we see, one is biliary or Roux-en-Y or gastric exclusion. So gastric exclusion, we have to use other techniques, not the normal techniques, because there is no stomach. So either we have to use a EUS or we have to use laparoscopy. So EUS I'll not be showing, but I'll show one video of laparoscopic ERCP. In biliary 2 anatomy, we can use a duodenoscope, and we can do with a forwarding endoscope. We can do a EUS, that is hepatogastroscopy. We can do PTBD, as well as we can use a single balloon versus double balloon endoscopy. Whereas a patient who has Roux-en-Y, a Roux-en-Y with normal papilla, some people have attempted, but only thing is the chances of complications are high because of sometimes the length is long. But if patients who have a Hepjed, Roux-en-Y Hepjed, then a duodenoscope, a forwarding endoscope cannot be used. We can use EUS drainage, but we are not discussing that. And PTBD can be used, and a single balloon and double balloon endoscopy can be used in patients who have Roux-en-Y. And in gastric exclusion, either we can use PTBD or a single balloon, double balloon, or we have to use a EUS, that is edge technique, but I'm not showing that here. So these are the normal anatomy. This is the biliary anatomies. So this is biliary 2, this is biliary 1. You can see that it's a long afferent limb, and here somewhere in afferent limb there's associated papilla like this. And this is a gastric exclusion procedure. You can see that the stomach has totally been excluded, and there's a long loop, which there's a jejunostomy, and then it forms here, and here is a papilla here. And this is classical Whipple's, in which the pylorus is not preserved, and this is a pylorus preserving Whipple. So these are the anatomies we normally see. This is normal. This is a hepatogenostomy. This is also hepatogenostomy. So these are the anatomies we should always take in consideration before we consider any attempt of ERCPs in that. And this is a sketch made by one of my paper. This is a gastric access loop. This is done basically by after there's a bile duct injury and patient, the surgeon does a hepatogenostomy. So to gain access easily, they do usually make a gastric access loop, which is just in the duodenum or in the proximal antrum. And this is a classic hepatogenostomy with Roux-en-Y anastomosis. And these are the fluoro images of that. So standard of care at the moment in altered GI anatomy is PTBD versus surgical revision. But the problem with PTBD is that there are multiple sessions are required. It is uncomfortable to the patient. And the clinical success as well as the clinical outcome is divided by physician. So patient has to go in between radiologist as well as the physician. And the re-intervention rate and gastric migrations are very high in these patients. So there are the shortcomings for PTBD. And what are the problems in surgical revision? One is it's associated with high morbidity. Complications are high if, especially after repeat surgery, and the cost goes up. after with surgical revision. So there are no head-to-head trials between PD and endoscopic drainage in altered GI anatomy. So we have comparison studies with the normal anatomy, but not much with the papilla. So I'll show you one video. This patient had, this is a ERCP being done with a double balloon endoscope. You can say fusion on is here, and this is how does in a Billroth 2, how does the papilla will look like. And already the scope is inside the duodenum, the descending duodenum, and we see where is the position of the cannula will come. This is a normal cannula which is used, a simple cannula or a Sohindra dilator, and it's little. So this is how ERCP is done in these cases. so learning point one will be that what should be direction of accessories. So this is a normal duodenoscope, and this is a normal papilla, and you can see that the position of the accessories is from 4 o'clock in between 5 o'clock in normal. But when we go for a patient who has a procedure with a single balloon or double balloon scope, the position of accessories will come from the between 6 and 7 o'clock position. So that will be always, that orientation should be always in mind when we attempt ERCP in the patients. And the length of accessories already have discussed. So in duodenoscope we can use accessories which are 250 to 300 centimeter, but in these situation the length of accessories should be more than 300 centimeter because the scope is 200 centimeter plus. So, and what are the learning point two is that if available, so we should use cap. So you can see that there is a papilla here. After, and the cap helps in seeing the papilla very easily in patients with the enteroscope. This is a patient who had a normal hepatojejunostomy with intact papilla. So with the cap, the things become easier and easy to see the papilla and get access to the papilla and the bile duct. So other thing which learning point is direction of papilla and EPT. So if we see this is a ERCP via duodenoscope in a Billroth 2 anatomy, and so the orientation is reversed. So like in normal anatomy, the papilla is like this, and the bile duct is between 11 and 1 o'clock. Whereas in patients who have Billroth 2, because of the loop as well as the position of the scope, the papillar direction will be always between 4 to 6 o'clock. So the pancreatic duct will be on the upper side. So it's advisable if your wire has gone into the PD first time. So try to put a PD stent like in this video, and after that try to cut either with a sphincter NKP, that is a needle knife, or do a sphincteroplasty, because the complications are very high in Billroth 2 because of this, because of the alteration in position. And you can see here in the video that it will show a cholangiogram also where the scope is rotated. So you see it's always done in long loop, and the position of bile duct is not as similar as we do in a normal ERCP. This is a similar cholangiogram in patient who had a Billroth 2. You see the position of the scope. So scope is rotated and it will be twisted. So either it will come at the 6 o'clock position, or if we come into the normal position, then it will be showing in a opposite direction. And this is another patient, two patients. One, this is patient who had a hepatojejunostomy. This is the jejunal anastomosis, and in this with hepatojejunostomy with no papilla. So this the further ERCP will show how the anastomosis will be there. And this is the normal which I showed earlier, which with this one Billroth 2 anatomy. And the bile is the one of the thing which will guide us how to approach the front limb in this patient. And it because there's no papilla, so it will directly come to your face. Only thing is the orientation, which side are you comfortable. So this, if we are doing it with a enteroscope, so ideally bring it to either 6 or 7 o'clock, because accessories will come. If the opening is like this, so our accessories will come from the opposite direction like this. So it will be difficult for accessories to reach. So I will present a few cases which I dealt. So a 22 years old male who presented with the EHPO, he had a history of bile duct surgery for a choledochal cyst at the age of 5 years, and now he presented with features of cholangitis, and because of cholangitis, a PTBD was done. And the radiologist was not able to negotiate and dilate the stricture because the duct was full, and so this is the MRI of that patient, and we can see that the whole duct is filled with a large stone, and this is the PTBD images, and when the cholangiogram was done, then the whole intrahepatic ducts were filled with stone. This is the cholangiogram that guy is going to jejunum. But the radiologist was not able to do so. What we attempted was a rendezvous via PTBD. This wire was passed into the jejunum, and this is a PTBD catheter. So it was grasped with and the wire was pulled inside the endoscope, and after that the track was dilated, and this is the anastomotic site, the stricture at the anastomotic, and you can see that a lot of stones are inside the whole intrahepatic portion of the bile duct. So laser lithotripsy was done via endoscope, and most of the stones were pulverized. So you can see that the stone is getting pulverized with the YAG laser, and most of it was pulverized with, with the stone was crushed, and at the end of the first session, I think 60 to 70% clearance was done. It took around 3.5 hours for the first session, and most of the stones were then cleared, and at the end we placed stents, 3-4 stents inside, plastic stents, and later on he required 2 sessions, March and June, and after 2 sessions the duct was cleared. So, and he was advised surgery, and he was lost to follow up. So the next learning point is how should we approach in patients who have a hepatocytosis. So we should judicially use fluoroscopy, and in the afferent loop, what is the afferent loop? Will always have an acute bend. It will not be like a smooth, like opening like into a efferent. So we should always be aware that it will always either be at around 45, 90 degrees, or sometimes even more than that. So acute bend will be there when there is a afferent loop, and we should be aware about the type of loop. Suppose patient has biliary 2 with anticolic anastomosis, then anticolic is around 10 to 20 centimeter longer than the retrocolic component. So that's why it's important to discuss with surgeon what type of surgery has been done. And another type of anatomy which we see normally now is coming up is post-transplant liver transplant hepaticogynostomy in a patient, or they have a double duct or a triple duct anastomosis. So this patient had a ACLF and a PSC related CLD, and he underwent a hepaticogynostomy. After 3 to 4 months, he started developing LFTs and range LFTs, and ultrasound was MRCP was done. There was hemophilia with minimal IH-BAD. So the intervention radiology people told that PTBD is not feasible, and we did a EUS. EUS also showed that the ducts were minimally dilated, less than 2 millimeter on the IHB on the left lobe. So what we planned was so these are the normal anatomies. This is the single duct anastomosis. The one opening is anastomosed to the jejunum. But when there is 2 openings, this is a double ductal anastomosis. Sometimes the surgeons, I'll show you later on, they do a triple anastomosis and multiple anastomosis. So this patient then had PTBD on the right one of the lobe, that is the right posterior lobe. They did a PTBD, but the left lobe, due to the double duct, they could not reach the second duct. So we attempted ERCP from this, and we were able to cannulate. But the other, you can see that the PTBD catheter is here. So this was 3 to 6 months later, and the thing was that it has separated from from the jejunal end. So, and this patient was from outside India, and she didn't come back. So, a patient who had a PTBD in one and a ERCP in one, and we lost her to in follow up. But thing is, these patients are going to come because of the increase in liver transplant in our settings now, and many patients like who have a ductal problem prior to surgery, they may have a double duct. So this patient has a double duct like this on the right side, and one we are able to cannulate. This is the right anterior, but the right posterior was already had a PTBD, and this portion of duct, like around 2 centimeters, had atrophied. So there was no duct left, and we wanted her to follow up, but she didn't follow up. So these are the anatomies. So this is another patient with post transplant uh, uh, hepatogynosmy, and you can see that the duct anastomosis has been done like this, and this is the MRCP of that patient. You can see that the two ducts are entirely separate. So in these patients, you should be cautious that you have to find both openings, try to stent both of these openings rather than doing one, because if you do only one, the purpose is not solved. The patient will still have deranged LFTs, and the graft may fail. And these are the ducts which I was saying. So this is the single duct anastomosis. This is the double duct anastomosis. This is a triple duct anastomosis. So three duct anastomosis, different portions of jejunum. So near future, we may see such patients because of complicated intrahepatic anatomy. So, and the ERCP is the purpose, because you can see that the IHBRD is not there, and these patients may require an endoscopy, because EUS may also not help in these patients. So, what is the data if we use a single balloon versus double balloon in such patients? So the data is comparable. There are similar complications and success rate, but the data shows that the time of procedure is less in a single balloon enteroscope. And this is a paper which in patients who had a Roux and they use a with the intact papilla. So they showed that the success rate was very high, from 89 to 100%, and depends upon the type of single balloon. And the second attempt was similar, and the total success rate was high. But minded, these are the centers who are referral centers. They do around at least 10 to 20 procedures, 10 procedures per month, and and not like us who does only 1 to 2 cases, or even less per month. And another long series which used a double balloon endoscopy, I met with the operator who did this procedure. So it was around 10 years of series, around 931,000 procedures in 502 patients, and used a new double balloon ERCP scope that is made by Fujinon, which is presently not available in India. And the anatomy was chiefly roux or other hepatogynosmy, and they were able to reach in 99% of patients to the blind end. Therapeutic success was 100% in stone and strictures, and there was around 5% of adverse reaction. But this operator or this group is doing such ERCPs from last 15 years. So that's why the yield is very high, and it may not be replicable in our patients because our number is so less. So we had our group also published a paper on similar, that if patient has presented to us with obstructed biliary system, we should do imaging like a MRCP or CT to see the what is the anatomy like, and assess the anastomotic stricture. If we have a endoscopic expertise and we have a high volume center, we should attempt endoscopic drainage. But suppose we have no expertise and we don't have a high volume center, I think we should either do refer a patient for a PTPD. If that is also not available, either send the patient for surgical revision. So to just finish last, this is a patient who had a gastric exclusion. You can see that the stomach is excluded. There's a jejunal limb which has been interposed between the bariatric procedure, and there's no access between the papilla and this one. So there's a laparoscopic has been done. So this they are trying to find the urine wire limb. Then what they do is they secure the the duodenal limb, and they are trying to secure before they cut so they are now cutting the jejunal loop, so that a hole is created, and then the scope can be passed, and then the duodenoscope is introduced into the opening which the surgeon creates, and ERCP. So you can see that ERCP, this looks like a normal ERCP, but the wire has gone into a pancreatic duct, and because the anatomy is reversed, what we saw in the see the wire has gone, looks like a bile duct, but it's basically a pancreatic duct. So this will happen if patients who have altered anatomy. So if we see and get a PD in the first attempt, we should always put a wire and a stent. We should not wait that we should be attempting again, and then the big path becomes easy. So in this case, because of it went into PD, so the next, then the operator will do a pre-cut, open the bile duct, and complete the ERCP. So I've done two cases like this because we don't have Axios. If we use Axios for the upcoming H procedure, the cost of procedure will become very high, and that is one of the issues which we feel. So my conclusions and take home message that is PTPD is still standard of care in altered GI anatomy. Endoscopic drainage is feasible, safe, and comparable as compared to PDPD. Endoscopic expertise and instruments are not available widely, especially for single balloon and double balloon related ERCP. And endoscopic technique has a long learning curve, and the complications are very higher in Billroth anatomy. So the endoscopic should be very careful when they attempt ERCP in patients who have Billroth, especially with a duodenoscope. And single balloon, double balloon, pediatric colonoscope or adult colonoscope can be used, and surgical revision can be used as a last resort with varied outcomes. So and the thing which I would like to raise, famous saying from Albert Einstein, that the difference between genius and stupidity is genius has its limits and knows its limits. So you should know your limits. If you know that everything is available ready in your center, then I think you should attempt ERCPs in such patients. But if you don't have a backup, or your surgeon is not very keen, or you don't have a surgical backup who can help you in such patient develops a complication after attempting such ERCP, it's better to wait for some time, gain some experience, and then attempt.